morning. Yeah. Thank you for the invitation, Roberto. I'm going to talk about bilateral cleft lip. And I'm trying to talk less lectures that I have about using lip adhesion as a part of the treatment. That's the principle that Spina published 50 years ago, and then we have used. This is Spina, and his principles is based on the dimension of the prolabium and the projection of the premaxilla. If I have a small prolabium in very big projection of premaxilla, you should do adhesion. That's the principle of his treatment. In 1963, he said that the prolabium forms an integral part of the lip and therefore should be utilized entirely, and the premaxilla should not be touched. He published this like 60 years ago. And his principle is start using adhesion on one side, and after adhesion the other side with 6 months, and then definitive surgery 4 years. Nowadays, we're doing in 2 stages, adhesion, bilateral adhesion, and 4 years the definitive surgery. You can see this patient with a very protruding premaxilla. After 6 months, we have this situation. The premaxilla is going back because the function of the muscle is linked that we create. And with 4 years, we can see this patient in the moment that the definitive surgery, I have the premaxilla in the position. Then I can decide the size of my prolabial and the nose repair that we can do this moment. We should avoid the tension in the suture. We don't want to have a situation like this that we can see when you see the primary repair in the first moment, because it's different when you do surgery in patient like an incomplete and a very wide complete cleft. Then we need to decide if a patient like this, I would do adhesion. So we have a different kind of, like this, a rotated premaxilla, sometimes a small prolabium, sometimes over-project premaxilla. So if I have this situation, we could use adhesion to bring this premaxilla back. So we're not doing 2 steps of adhesion, but we're doing just 1 step, and the definitive surgery is 4 years of age to repair. When I have a good relationship of the arch and prolabium very wide, I can do a definitive surgery in this moment. And what is the effect of the lip adhesion? The lip adhesion can bring, after 3 months, a situation like this to this, just 3 months, without any orthopedic, without any taping, only adhesion, only muscle function. And 4 years, the patient is like this occlusion, then I can do the definitive surgery. So lip adhesion is not a big surgery. It's just a 45-minute surgery. I can permit later treatment of this lip. We have we can see the patient after 10 years. Physiological reposition of this premaxilla, and we can get, with this adhesion, enlargement of the volume and the dimension of this prolabium, become easier to repair this later. So what is easy? This patient with 3 months to 6 months with this very wide cleft, or to do this repair with 4 years after adhesion. So this is one patient that we have this, a very protruding premaxilla. We perform adhesion with 6 months. After 4 years, the definitive surgery, then I redo rhinoplasty here, and we can see here 10 years follow-up. So I have in this patient right now a good relation, good shape of the lip, no tension, the lip is good, the projection of the premaxilla, and the occlusion is good. This patient is going to do a alveolar bone graft in this moment. When you see this paper from Mulliken, he has 75% of the orthognathic surgery using his technique. His paper was published in 2007. So it's important to note that the surgery is not good to be good. When you see this paper published by Berkowitz, he said that the history shown that this main sign of plastic surgery has always failed, and the orthodontist proving that the delay surgery could be more beneficial for this patient than avoiding surgery in this moment. Another paper published by Lozi in 2015, he said that the patient with unoperated cleft experience has a similar growth than non-operated normal patients. So we should pay attention in this lip repair because our surgery creating maxilla hypoplasia. So we should have work better on this lip repair. This one patient with a very protruding premaxilla, 5 years of age. I did adhesion, 4 years lip repair, 10 years he had a very protruding here. I performed a setback, alveolar bone graft, 18 years follow-up, no orthognathic surgery. This is his occlusion. This is his face. So we can do a this is the patient, 20 years follow-up. So when you do a spina, I change for complete to incomplete, and it's become easier to repair this patient. Another patient, 10 years follow-up, this is a pre-op, and 10 years after, we can see this patient, 10 years, and the results. Another patient, 12 years follow-up, very protruding, 10 years, 12 years here. This is the pre and post the patient. Another patient, 15 years follow-up, and we can see this post-op and the occlusion that we have this patient. Another patient, 15 years follow-up, very wide cleft, very protruding, adhesion, definitive surgery, alveolar bone grafting. This is my patient with 15 years. Another one, 12 years follow-up, a very wide cleft, very wide bone here, the alveolar, adhesion, definitive surgery. We can see the patient, 12 years. Another patient, 10 years follow-up, 17 years follow-up. This patient arrived to me with 3 years. I did adhesion, definitive surgery, 20 years follow-up. Another 15 years follow-up. So it's important to continue to see this patient because if you do the surgery and not follow this patient, you're going to see that the patient has a big problem with the maxillary growth. Here's 20 years of follow-up. Another boy, 18 years, adhesion, alveolar bone grafting. He's coming to do the nose. We can see here after finishing his treatment, the nose repair, and then we can see the post-op. This patient, I don't have the pictures before because it's in the slides time, so I lost the picture, but she came back to me 23 years only with adhesion. She didn't come to the definitive surgery. I performed the definitive surgery, and then we can see 23 years follow-up. So a spinal technique using a lip adhesion is a surgery that we can perform for this kind of patient with a protruding premaxilla, very weak prolabium. And we decide to do the definitive surgery later with around 4 or 5 years. Then I can decide how big I want to have these cupido bows, the philtrum, and I can define better the size of this philtrum, wideness, and I have a less posterior distortion of the maxillary growth and the lip growth also. So I can do this surgery, deciding to do this later. So that's how I intend to present. Thank you very much.